Hello, everyone. I would like to thank Doctors Langer and Garan for inviting me to speak today at the Personalized Therapies in Thoracic Oncology virtual meeting. And I thank all the organizers for making this such a pleasure to do a virtual meeting seamlessly. I will be discussing immunotherapy in non-small cell lung cancer as it relates to specifically frontline therapy. I'm Dr. Charu Agarwal. I'm the Leslie Heisler Associate Professor for Lung Cancer Excellence at the Abramson Cancer Center at the University of Pennsylvania. So today I will be talking to you about frontline therapy as it relates to immunotherapy. However, I think before we proceed on to my talk, I would just like to highlight the significant advances we have made in the management of non-small cell lung cancer. Here is an article from New York Times from last year that demonstrated that cancer death rate in the United States dropped significantly. In fact, in a single year between 2016 and 2017, we saw a decrease of about 2.2% in cancer-related mortality, which was largely driven from lung cancer advances. And on the right is a recent paper from New England Journal of Medicine that shows the trends and incidence, as well as incidence-based mortality in lung cancer in the United States over the past several years, starting from 2001. And as you can appreciate, there has been a consistent decline, whereas survival has continuously increased. I would also like to highlight that these data probably capture the advances in targeted therapy that started in about 2011, 2013, as you can see with this check mark with the first availability of EGFR TKIs. And I like to highlight this here because we are just starting to use immunotherapy over the last few years. And I'm confident that over the next 5 to 10 years, we'll continue to see significant improvements that will be garnered not just by advances in targeted therapy, but also spurred by an accelerated approval of a myriad of immunotherapy agents as well as combinations that we have today. So speaking of agents that are available, we have several different agents, and management in non-small cell lung cancer is becoming increasingly complex. Here I show you just a snapshot of what our NCCN guidelines look like, specifically for patients that don't have a targetable mutation and have a PDL1 expression of 1 to 49%. And we never had this many options for non-small cell lung cancer, and you could see it's mind-boggling in terms of should we use monotherapy, should we use a doublet, should we use a triplet, or should we even be thinking about a quadruplet? Before we go into various clinical trials and dissect this data a little further, I would like to just put in a plug that testing for molecular markers remains paramount. So before we commit a patient to immunotherapy or chemoimmunotherapy, we must ensure that they don't have a targetable alteration where they may receive benefit from targeted therapy instead. Unlike other solid tumors in non-small cell lung cancer, PDL1 testing still remains quite important. And some of our management decisions are still hinged upon PDL1 expression. There have been several new FDA approvals, some of them within this year alone. And this is a slide that I borrowed from Dr. Karen Kelly that's displayed here, which shows you the number of approvals that have come through, starting with the initial approvals of Pembrolizumab in October 2016 based on the KEYNOTE 24 trial. This was followed by single agent approval of Pembrolizumab based on KEYNOTE 42 trial. And then we also saw approvals of combination therapy based on KEYNOTE 21 as well as KEYNOTE 189. Most recently, we saw approvals for doublet immunotherapy based on the CheckMate 227, and these are the most recent approvals from May 2020, where nivolumab and ipilimumab were approved, as well as approved in combination with chemotherapy based on the CheckMate 9 LA data. It's important to also highlight that recently atezolizumab garnered approval for use in patients with PD-L1 greater than 50% based on the Empower 110 trial. And before this, atezolizumab had garnered approval in combination with chemotherapies or targeted therapies based on the Empower 150 and Empower 130 trial. Squamous cell cancer should not be forgotten. There is a specific approval for use of combination chemoimmunotherapy in patients with squamous cell cancers based on the KEYNOTE 407 trial, something that we've been using in our clinics for the past year plus. So as you can imagine, there is increasingly available options and increased complexity. But I would like to just go back and really begin where it all started in the first line setting. So this was really a paradigm-changing trial. KEYNOTE 24 was a first-line trial that evaluated the utility or efficacy of pembrolizumab versus chemotherapy in patients with untreated stage 4 non-small cell lung cancer that had PD-L1 expression of greater than or equal to 50%. Patients could not have an activating EGFR or ALK mutation. Patients could not have brain metastases, and no active autoimmune disease were required as an entry criteria. 300 patients were randomized to receive either pembrolizumab at a flat dose of 200 milligrams every 3 weeks for 2 years, or platinum doublet chemotherapy based on histology. Primary endpoint for this trial was PFS, and we first heard about these data at the ESMO meeting in 2016. Overall survival was a secondary endpoint. And here you will see that the response rate using pembrolizumab was much higher in this patient population that was selected for PD-L1 greater than 50%. We saw a response rate of 45% with a 28% response rate seen in patients that received chemotherapy. We saw significant improvements in both progression-free survival as well as overall survival as depicted here, with hazard ratios of 0.5 for progression-free survival and 0.6 for overall survival, leading shortly thereafter to an FDA approval for patients that have greater than 50% PD-L1 expression that were treatment naive. Again, I think this really set the stage for upfront use of immunotherapy in metastatic non-small cell lung cancer. This was followed later by the KEYNOTE 189 trials evaluating triplet or chemoimmunotherapy versus chemotherapy. Very similar patient population. These patients had to be untreated, stage 4 non-squamous non-small cell lung cancer without EGFR or ALK alterations, with good performance status, no symptomatic brain metastases, and about 600 plus patients were randomized to receive triplet that incorporated pembrolizumab, again at that flat dose of 200 milligrams, with pemetrexed, 500 milligrams per meter square, administered every 3 weeks. And there was investigator choice to use either carboplatin at an AUC of 5 or cisplatin. 4 induction cycles were administered, followed by maintenance using both pembrolizumab as well as pemetrexed. The control arm received the same chemotherapy combination and maintenance with a placebo instead of pemetrexed, and there was an option to cross over to pembrolizumab at the time of progression. Again, this was designed at a time where we already had data to support second-line use of immunotherapy, be it nivolumab, atezolizumab, or pembrolizumab in the second-line setting. Here we saw overall survival data at AACR in 2018, and as you can see, in the intent to treat population, hazard ratio was 0.49, with a significant improvement in overall survival for patients that received the triplet, with a median overall survival that was not even reached at the time of this data presentation. We saw, again, that response rates were higher with the triplet at about 47.6%. And we saw that overall survival by expression level of PD-L1 didn't really matter. We saw that overall survival was improved across all different expression levels, but perhaps the degree of improvement was highest, as you can see here, in patients that had PD-L1 greater than 50%, with a hazard ratio that was even more impressive of 0.42. So about 600 patients. I would like to highlight that the PDL1 expression categories on this trial were very well balanced, mirroring the usual prevalence in clinic of about 33 to 34% in each of these categories. And we had never seen a hazard ratio of 0.49 in a frontline non-small cell lung cancer trial that was not using a targeted therapy. And we saw benefit across all subgroups, with the response rate highest in the PDL1 high, with a response rate of about 61.4%. Of course, when these data became available, we had already seen data from KEYNOTE 24. And therefore, there were cross-trial comparisons that were called into place with KEYNOTE 189 displayed on the left, showing data specifically for PDL1 greater than 50% expression, and KEYNOTE 24 on the right. And as you can see, overall response rate with the triplet was slightly higher at about 61% compared to 49% with pembrolizumab single agent. But it's important to highlight that at the time of this cross-trial comparison, when KEYNOTE 189 had just been released, we had much longer follow-up on KEYNOTE 24, and it looked like that the 2-year landmark survival was much higher at 51%. We now, of course, have much longer survival, and I'll go into these data a little bit more in detail. It's worth mentioning that KEYNOTE 42 also evaluated pembrolizumab in the frontline setting versus chemotherapy, albeit in a slightly different patient population. This did lead to pembrolizumab approval, and I think it's worth highlighting some of the drawbacks and some of the highlights of this trial. Again, untreated, locally advanced or metastatic non-small cell lung cancer with a PDL1 expression of greater than or equal to 1% were included. Rest of the enrollment criteria were very similar to KEYNOTE 189 as well as KEYNOTE 24. And there were much higher number of patients. Squamous histologies were allowed, and patients were randomized to receive, again, either pembrolizumab flat dose every 3 weeks for 2 years, or histology-specific chemotherapy using carboplatin. Primary endpoint was overall survival in TPS greater than 50, 20, as well as 1% populations. This was presented at the ASCO meeting. And here is the data at first blush. In patients that had TPS greater than 50%, pembrolizumab far exceeded performance compared to chemotherapy. Here you will see a hazard ratio of 0.69 compared to chemotherapy. And in greater than 1% or greater than equal to 1%, we still saw somewhat of an overall survival improvement. However, the hazard ratio was not that significant, coming in at 0.81. The p-value was still significant. However, there have been critiques that the overall survival in the comparator arm perhaps was less than expected, and no crossover was allowed for these patients. Here's the overall survival for the middle of the pack, the 1 to 49%. We did not really see a clear advantage for these patients. So in summary, majority of these patients, about 47% of the patients on this trial had high PDL1 expression of greater than 50%, perhaps that drove the majority of the benefit that we saw on this clinical trial. Again, remembering that the usual prevalence for these high PDL1 expressors is about 33%. Hazard ratio for overall survival for greater than 1% and the 1 to 49% was in the 0.8 to 0.9 range. Again, maybe not really justifying single agent pembrolizumab use for these patients, at least not based on this data alone. But regardless, based on this clinical trial, pembrolizumab did become available for use for PDL1 greater than or equal to 1%. Based on KEYNOTE 42, again, cross-trial comparisons were brought into question. And here I would like to pull back my initial slide comparing KEYNOTE 189 and 24 here, and really transpose KEYNOTE 42 here, looking at TPS greater than 50%. Here, the hazard ratio was 0.69, again, largely mirroring the experience that we've had with pembrolizumab single agent, that yes, this is an active agent for these high expressors. And the 2-year landmark survival here was about 44.7% versus 30%, with an overall response rate of about 40%. Again, a very good option for patients that have high PDL1 expression. What about squamous histologies? KEYNOTE 407 was a trial that specifically evaluated a triplet regimen in patients with squamous non-small cell lung cancer, largely mirroring the trial design of KEYNOTE 189 that was presented at AACR in 2018. This was presented shortly thereafter at the ASCO annual meeting, and you will see that pembrolizumab was combined with carboplatin with either paclitaxel or nab-paclitaxel for a total of 4 cycles in the induction setting, and pembrolizumab single agent was continued for the experimental arm for a total of 2 years. And this was replaced by a placebo in the standard of care arm with an optional crossover at the time of progressors for patients in the standard of care arm. Here again, we saw significant improvements in overall survival for patients that received Pembro plus chemo. Hazard ratio was about 0.6. Benefit was seen across all PD-L1 stat expressors, similar to what we saw in KEYNOTE 189. Very large trial, about 559 patients. Again, I think a very well-balanced trial. PD-L1 expression largely mirrored the clinical prevalence of about 33 to 34%, and a hazard ratio again of 0.64 in squamous cell non-small cell lung cancers was actually a welcome relief for our patients with this histology. And given that the benefit was seen in all subgroups, this led quickly to its acceptance, and we started using this very quickly after these results came out for our patients with PD-L1 less than 50%. I would like to highlight a few other clinical trials that have been approved, mainly in non-squamous non-small cell lung cancer, using atezolizumab, which is a PD-L1 inhibitor, in the frontline setting. Empower 130 was a clinical trial that, again, enrolled patients with or treatment-naive non-squamous non-small cell lung cancer. Any PD-L1 expressors were allowed, and 4 to 6 cycles of induction chemoimmunotherapy were utilized on this trial using carboplatin plus nab-paclitaxel in combination with atezolizumab, followed by atezolizumab maintenance. And this treatment could continue until an investigator assessed loss of clinical benefit. There were co-primary endpoints of PFS as well as overall survival in the intent to treat population. And then there was a key secondary endpoint of overall survival and PFS in intent to treat population and by PD-L1 expression. Atezolizumab was administered at a dose of 1,200 milligrams every 3 weeks. And here are the data from Empower 130. We saw, again, the similar sort of signal that triplet chemoimmunotherapy led to an improvement in progression-free survival, again with a hazard ratio shown here of 0.64, and translated into an overall survival benefit with a hazard ratio of 0.79. Here you can see the 1-year and 2-year landmark overall survival percentages with the triplet of 63% as well as 40% respectively, higher than what we would expect with chemotherapy alone. Safety profile of atezolizumab plus chemotherapy was consistent with what we would expect with individual monotherapy, and there were no significant new safety signals that were noticed. Again, this led to approval of this regimen and is now included in the NCCN guidelines as a treatment option for patients with treatment-naive, non-squamous, non-small cell lung cancer. Empower 130 looked at building upon the previous regimen of carboplatin paclitaxel as well as bevacizumab, which used to be our preferred regimen before pemetrexed was widely used for non-squamous non-small cell lung cancer. But really they asked the question, can adding immunotherapy to a bevacizumab and chemotherapy backbone improve outcomes even further? This was a large trial. Recurrent non-squamous non-small cell lung cancers were enrolled, about 1,200 patients that were randomized into 3 different arms. Arm A included atezolizumab with chemotherapy, that is carbopac. Arm B included both atezolizumab as well as bevacizumab. with carbopac, and arm C, which was the control arm or the old arm of carboplatin, paclitaxel, or bevacizumab. All treatments in the induction setting were administered for 4 to 6 cycles, and they were followed by maintenance therapy as outlined here. In arm B, atezolizumab and bevacizumab were both administered as maintenance, and all patients received treatment until progressive disease. Patients were also followed for survival follow-up. And here are the results of the overall survival of arm B, which is the quadruplet arm, versus the control arm C. And here you will see an improvement in overall survival, both at 12 months as well as 24 months, with a hazard ratio of about 0.78, with a p-value that was significant. This did have a tail to the curve, although not quite far away from the control arm. However, there are patients that have been reported to have longer follow-up. What's important on this trial is that arm A versus arm C did not seem to be that different. So if you look at the atezo plus carbopac versus the bevacizumab plus carbopac, the hazard ratio was less impressive at 0.88. And these are data from the time point where the trial had a median follow-up of about 20 months available. Speaking of other combination clinical trials, so I discussed with you Pembrolizumab single agent. I talked to you about triplet chemotherapy. We also saw data from quadruplet immunotherapy incorporating bevacizumab in the Empower 150. But what if we were to think about a chemotherapy-free approach? And most recently at the ASCO meeting, we saw data from CheckMate 227, and this is the 3-year update. So long-term follow-up was available on some of these patients. This is a complicated trial design, to say the least, and many of us have seen this trial presented in different iterations before. But let me refresh you and walk you through some of the data from this 3-year update. Stage 4 or recurrent non-small cell lung cancer with any histology were included if they did not have an EGFR or ALK mutation. Patients could receive either Nivo plus IPI, or chemo or Nivo if they had PD-L1 expression greater than or equal to 1%, or if they had PD-L1 expression less than 1%, they could get Nivo, IPI, chemo, or Nivo plus chemo. And at this year's ASCO meeting, we saw updates on the Nivo plus IPI versus the chemotherapy arms. And here are the baseline characteristics of this part 1 analysis. Baseline characteristics on this trial for this part 1 were well balanced across the treatment groups, including Nivo monotherapy as well as Nivo plus chemo. And here you can see the percentage distributions of patients based on PD-L1 expression, with about 70% of the patients having greater than or equal to 1% expression. We saw that overall survival with Nivo plus IPI was higher compared to chemo or compared to nivolumab in patients with PD-L1 greater than or equal to 1%, with a median overall survival of 17.1 months. And 33% of these patients were living at the time of the 3-year overall follow-up, as shown here. Also important to mention that patients less than 1% seem to have a benefit from Nivo-IPI as well, with an overall survival of 17.2 months versus 12.2 months with chemotherapy. It's important to remember that Nivo-IPI is not currently approved as a combination therapy for PD-L1 less than 1% at this time. Safety data are shown here. I was pleasantly surprised to see that grade 3 for treatment-related AEs leading to discontinuation was only seen in about 12% of the patients, which is slightly lower than I would have anticipated for such a combination. Again, stressing the importance of dosing and also following up and recognizing immunotherapy-related adverse events quickly. CheckMate 9LA is another study evaluating a quadruplet, but using Nivo-IPI plus 2 cycles of chemotherapy. This was presented at the ASCO annual meeting. Very similar trial entry criteria. Patients received every 3-week Nivo, every 6-week IPI, and every 3-week chemotherapy only for 2 cycles. And the control arm received chemotherapy for 4 cycles with optional maintenance. Again, this trial also showed us that the quadruplet CheckMate 9LA regimen had an improvement in overall survival with an overall survival of 15.6 months versus 10.9 months with chemotherapy. This is approved as a regimen. However, we don't quite have the long follow-up that we do with some of the other trials. Here you can see that overall expression by PD-L1 expression level showed that this combination was active amongst all different subtypes of non-small cell lung cancer, and progression-free survival was slightly improved as well, 6.7 months versus 5 months for chemotherapy. Overall response rate as well as duration of response are shown here. A disease control rate of about 84% was seen with this combination, and duration of response seems to be much higher with the quadruplet at 11.3 months versus 5.5 months. This quadruplet was pretty safe, and as you can see, grade 3 for AEs leading to discontinuation with the quadruplets was only 16%. Most common treatment-related AEs were nausea, anemia, asthenia, and diarrhea. Again, things that we can manage very well and efficiently as we take care of our patients. Here are some of the treatment-related select AEs that were presented on this trial. And as you can see, most of these were related to chemotherapy-related toxicities like anemia, neutropenia, and alopecia. And we saw some skin toxicities as well as endocrine toxicities, which we can expect with immunotherapy. So based on these trial data, FDA approved nivolumab and ipilimumab along with chemotherapy for first-line treatment of metastatic non-small cell lung cancer, regardless of PD-L1 expression, really increasing the number of available options that we have now. And really, it's a question of how do we incorporate these different combination approaches into our treatment paradigm. And here is an algorithm that I put together that I would like to walk you through and, sort of think about when we see our patients, what should we be thinking about? So patient walks in the door with metastatic non-small cell lung cancer. Histology is still very important. We look at non-squamous or squamous. I'll talk about our non-squamous patients first. If they have a non-squamous histology, very important to test for EGFR, ALK, BRAF, ROS1. The beginning of this slide is slightly outdated. We now have 7 biomarkers that must be tested that include RET, MET exon 14, as well as NTRK mutations, which all have targetable therapies available. So these are must biomarkers that must be tested. If they don't have a targetable alteration, in my practice, I still like to think about PD-L1 expression. For my patients that have PD-L1 expression greater than 50%, I now have 2 options. I can either use pembrolizumab based on the KEYNOTE-24 or atezolizumab, which was recently approved. I didn't show you the data, but it was based on the Empower 110 trial, showing very similar outcomes to the KEYNOTE-24 trial, where atezolizumab single agent led to significant responses in this highly specific group of patients that have PD-L1 expression greater than 50%. What to do for patients that have less than 50% expression? And I think we have several different options for our patients that have non-squamous non-small cell lung cancer. I discussed with you KEYNOTE 189 that incorporates chemo and Pembro. There is Empower 130 that incorporates nab-paclitaxel with atezolizumab. We have Empower 150 that looks at quadruplet, carbo, pac, bevacizumab, and atezolizumab. We have CheckMate 9LA that has only 2 cycles of chemotherapy and Nivo IPI. And then we have CheckMate 227, which is Nivo IPI, sort of our chemo-sparing approach for patients that have a PD-L1 expression of more than 1%. Any of these options are reasonable options, and I think have to be weighed in terms of what patients want. Alopecia is a significant concern for some of my patients, and I may choose a pemetrexed-containing regimen for those. Neuropathy is a significant concern for some of my patients, making me choose one regimen over the other. And then also, I think disease burden. performance status, as well as overall overall conditions of the patients, including how sick they are, may dictate what we use. It's important to remember that these regimens can also be used for our patients that have PD-L1 expression greater than 50%. However, most of the time, I, in my practice, tend to use monotherapy for my patients with greater than 50%. Similarly, if you were to do the same exercise for squamous cell patients, you can see that our options include KEYNOTE 407, CheckMate 9LA, or CheckMate 227 for the specific group of greater than 1%. I have not yet used CheckMate 9LA as I await further data, but I'm very intrigued at the option of using CheckMate 227 in this chemotherapy-free approach for those patients that specifically ask for such an approach. So in summary, we have many approaches available, but there are still unanswered questions in terms of what is the best maintenance therapy, what regimen should I start off with? And I think this cooperative group trial called INSIGNIA will answer some of these questions, where patients with non-small cell lung cancer, mainly non-squamous histology, will either receive treatment with pembrolizumab or get combination chemoimmunotherapy, followed by different either maintenance or second-line approaches for patients that have a PD-L1 expression greater than 1%, and may really answer our question of what do we start with, how many cycles, what do we maintain treatment with, and what should we use as our second-line treatment. So in summary, immunotherapy alone or in combination with chemotherapy has been the standard of care for patients with wild-type non-squamous non-small cell lung cancer, as well as squamous non-small cell lung cancer over the past 2 to 3 years. Lately, immunotherapy combinations with Nivo plus Ipi are now approved for first-line management, as well as quadruplet regimens incorporating 2 cycles of chemotherapy. I can't stress this enough, but testing for molecular markers remains paramount. And PD-L1 IHC is still important to make treatment decisions for patients that have wild-type non-squamous as well as squamous non-small cell lung cancer. Biomarkers such as TMB may become important in the future, and I'll talk a little bit more about biomarkers in my talk looking at immunotherapy combinations. And ongoing clinical trials such as the INSIGNIA trial will really help define further management. Thank you so much for the opportunity to present today, and I'm happy to take questions in our live session. Thank you so much.